I am Dr. Ebere Achibu, the Scientific Committee Chairman and the Vice Chairman of the Vitreo Retinal Society of Nigeria. And based on our earlier sent forms, we got the feedback from members, and so we have organized very interesting educative topics for the society and all those who will be joining us during our webinars. So we're going to hit the ground running. Before we start, I'd like to call on our chairman, Dr. Oladapo Onadipe, a fellow of the West African College of Surgeons, consultant ophthalmologist and retinal specialist, JOTES Specialist Eye Center, Ijebu-Ode, Ogun State, to give us a brief remark. Dr. Onadipe, you're welcome.
Thank you very much, Dr. Ebere Achibu. I really appreciate all you are doing for us as a society. Good evening, distinguished colleagues and elders. I am delighted to welcome you all to the first continuous medical education lecture series of 2025. The first quarter CME is going to be an interesting topic around the optical coherent tomography and its various applications. For that reason, we shall have a very stimulating scientific session today. And then in a fortnight, we shall conclude, because this is a topic that is very, very important for each and every one of us as ophthalmologists. And so we'll not be able to exhaust it in a day. And we felt we shouldn't compress it. Rather, we should spread it over 2 sessions. So today will be part 1, and in a fortnight, we shall have part 2. So it's not something any of us wants to miss. We'd like to say that please help us observe the house rules by keeping your microphone muted and turn off your videos if your environment isn't appropriate. Please kindly write your name and center on the chat so that we can have a proper attendance of today's meeting. And also, at the appropriate time, you'll be asked to drop your questions so that the house will not be rowdy. I want to thank everyone for coming, and I wish us a very stimulating academic session. You are all welcome.
Thank you, Chairman. So right now, I'm going to introduce the moderator for this session. Our moderator is none other than Dr. Victor Ume Chukwe-Buka. He is a fellow of the West African College of Surgeons, a consultant ophthalmologist, and a VRO specialist with the Eye Foundation Hospital, Abuja. Dr. Victor Ume Chukwe-Buka, you're welcome.
Thank you, Ma. And thank you, Chairman and Dr. Onadipe, and our chairperson, academic Dr. Chibu, for this privilege. And today we are discussing a topic that is very crucial to our practice. And we have seasoned results persons to guide us and lead us into the various parts of our discussion today. So our first speaker is none other but Dr. CHINEZE AGWEYE, who is a consultant ophthalmologist with the Tusuchara Foundation and the University of Calabar. She's a medical retinal specialist. She will be taking us through OCT in retinal diseases. After that, we would have our own distinguished Dr. Konkwo Ogugwa to take us through angiographies in retinal diseases. That's the OCT angiography, the fundus fluorescein angiography, and as well as indocyanine angiography. I hope we have a stimulating time and really look forward that our time will be useful and we'll be able to make the best out of our time under this topic. So without much ado, I would give the floor to Dr. CHINEZE AGWEYE to take us through OCT in retinal diseases over the next 20 minutes. So our questions can be dropped into the chat box, and we'll hope to take the questions at the end of the day within the perimeter of our time. Other questions would continue on our discussion and the discussion part of our forum. So Dr. CHINEZE AGWEYE, the floor is yours, please. Thank you. Let's make.
Not yet.
Please, you are muted. Unmute yourself. Okay, good.
I can see. You can speak.
Good evening, everybody. I'm Dr. CHINEZE AGWEYE, and I want to thank the Vitreo Retinal Society of Nigeria for the opportunity to give this talk on OCT. So without wasting so much time, we would begin the lecture. This is my outline for the lecture for today. The optical coherence tomography, which is also known as the OCT, is a medical diagnostic imaging technology that captures in microns the resolution in three-dimensional images of ocular tissues. It's non-invasive, non-contact, it's comfortable for the patient, and quick and easy to use. It's based on the principle of interferometry. The OCT uses the infrared light greater than 700 nanometers to measure the amount of optical reflectivity from the retina. So this light gets into the retina, and the different layers of the retina have different refractive indexes, and which, when the light make contact with the different layers of this retina, there's a back scattering of the light. It measures the intensity and time delay of light that is scattered from the tissue of interest. So this is just a brief principle of the OCT. A low coherence light, a low coherence light is sent from a device, and it passes through a beam splitter. It passes through the beam splitter and gets to the sample arm, which is represented by the eye, and then a reference arm. We need the reference arm so as we can have a measurement of the wavelength. And when it gets to these various, the sample arm and the reference arm, there is now a back scattering of the light through the beam splitter again, and it gets to the detector where there's an interference of the wave. And so we now have the waves in synchrony, and that's how we now get to see the pictures on the monitor. So the different types of, we have the different types of the OCT, the time domain, which is the first generation, the Fourier domain, which has the spectral domain, second generation, and the swept source, which is the third generation OCT. And this table here shows the difference. For the first generation, it had a movable reference mirror, while for the spectral domain and the swept source, it has a fixed reference mirror. The wavelength, as the generations improve, it increases. So for the time domain, it was 810 nanometer. For the spectral domain, it's about 1,052 nanometers. The OCT also have various scanning protocol. We have the line, that's the raster scan, the macular scan, which we would be using, or which we'll discuss later in the presentation. Then the radial scan, the grid, and the enhanced depth imaging. So the uses of the OCT, since this is for the retina, we have it that we could scan and find out different pathologies, such as the macular edema as presented in diabetic retinopathy, or diabetic macular edema, vascular occlusion. We could also pick up epiretinal membranes, vitreomacular traction, hard exudates as seen in diabetic retinopathy. We could also find pigment epithelium detachment as seen in wet age-related macular degeneration, drusen's as seen in age-related macular degeneration, and also ischemia in vein occlusion. The use of the OCT, it's very important to understand in understanding the pathogenesis, diagnosis, and improved monitoring of progression and assistance in quantifying response to treatment modalities in retinal diseases. It's also useful in monitoring surgical outcome in retinal surgery, such as macular hole surgery. It's also helpful in assessment and management of chororetinal diseases. OCT imaging and its biomarkers are vital in predicting visual outcome and treatment prognosis. Artificial intelligence also has a role to play in OCT. Researchers have developed artificial intelligence models that help to analyze some OCT biomarkers, fluid volume, and photoreceptor loss. So it's helpful in the accurate identification of retinal pathologies and make reliable diagnosis. Artificial intelligence also provides a rapid, robust, and valuable information about treatment response and predicts disease progression. So now let's start off with what the normal macular anatomy looks like on the OCT. There are 5 structures we have to look out for when we have an OCT macular printout in front of us. The first is the vitreoretinal interface. The next is the neurosensory retina, which is also referred to as the inner retina, the outer retina, then the retinal pigment epithelium root membrane complex, and the last is the choroid. The vitreous and the vitreoretinal interface. At this particular interface, it's dark in color. It's usually dark in color. It's a hypo-reflective space. And so this is the printout of an OCT, like the V-scan of the OCT. So up here, if we move all the label, it's the vitreous. So we have the vitreoretinal interface where the vitreous comes in contact with the retina. And this is a hypo-reflective space. Then at this point, where we have the fovea is the premacular fossa. Then there's the posterior hyaloid. This is difficult to see except when there is like a posterior vitreous detachment. But when it's there, when it's present, it's a hyper-reflective line, which is demonstrated here. So in 2014, an international panel of experts, OCT experts, came together to give a consensus of acceptable terminologies for retinal layers as visualized on the OCT. And so it was agreed on there that discrete, well-separated layers having good boundaries are referred to as layers or bands. And then the part of the retina that don't have recognizable boundaries will be referred to as zones. So while reading the OCT, macular OCT printout, we have hyper-reflective bands, hyper-reflective zones, hypo-reflective bands, and hypo-reflective zones, and then the choroscleral junction. The hyper-reflective bands, as seen in the printout, comprises of the nerve fiber layer, the inner plexiform layer, and the outer plexiform layer. These 3 layers I have just mentioned are in the neurosensory retina, and they give off the hyper-reflective bands because structures in these layers are arranged in a horizontal fashion. And so when the light from the OCT gets into the retina, into those layers, it strikes these various layers, and then there's a backscattering of the light, and it gives us a hyper reflective band. While the external limiting membrane and the retinal pigment epithelium, which is found in the outer retina, they also give off hyper reflective features because of they are highly pigmented. Then hyper-reflective zones also, these are found in the outer retina. These are found in the outer retina. They comprise of the ellipsoid zone and the interdigitation zone. Hyporeflective bands, which comprise of the ganglion cell layer, the inner nuclear layer, and outer nuclear layer. These are found in the neurosensory retina, and they are hyporeflective because these are just basically made up of cells. Then the hyporeflective zone, that's the myoid zone, the choriocapillary, and the choroidal layer is seen in the outer retina. So the inner retinal layer, which is referred to as the neurosensory retina, is made up of the internal limiting membrane, the fiber layer, ganglion cell, inner plexiform, inner nuclear, outer nuclear, and the outer plexiform and the outer nuclear. So this is a brief like anatomy of the neurosensory retina. And as I had earlier said, the nerve fiber layer, the outer plexiform layer, and the inner plexiform layer are hyper-reflective because their structures are arranged in a horizontal fashion. The nerve fiber layer is actually made up of the axons of the ganglion cells, which is arranged in a horizontal fashion. Then so we now have the outer retinal layer, which has 4 distinct hyper-reflective structure. So there is the external limiting membrane, which is the first layer up here. Then we now have the ellipsoid zone, which was formerly known as the IS-OS junction. Beneath it is the interdigitation zone, and then lastly is the retinal pigment epithelium and the broad membrane complex. Beneath it is the choroid. The choroid is basically made up of big three vessels. So we have the choriocapillaries, which are the smaller vessels and which is adjacent to the broad membrane. Then we have the settle layer, which is the medium to small size vessel, and the highlight layer, which is the outer choroidal layer, and it has the large choroidal vessel. So let's quickly look at the steps for reading the OCT retina scan. As we know, when we pick up the printout, we first have to look at the demographic to ensure that it matches with the patient in front of us. Then we now have the signal strength, the macular tomograph, ETDRS grid, fovea founder, the 3D macular thickness map, segmented ILM, segmented RPE map, and the macular parameters. I'll discuss all that in a moment. The signal strength, it's important that when we have a printout, we look at the signal strength, and various machines have various signal strength. For the Zeiss Cyrus, the best quality scan is at signal strength is when it's greater than or equal to 7. For the Heidelberg, it's when it's greater than 20, and for the top one, when it's greater than 40. Things that can interfere with the signal strength is when the patient has maybe a corneal opacity, unstable TF film, when there's lens opacity, or there's vitreous opacity, as present in our seen in vitreous, dense vitreous floaters or vitreous hemorrhage. So we would start this. The OCT I'm using is the Zeiss Cyrus OCT printout. So the first that we have on the topmost corner of that, the left topmost corner of the printout, is the fundus image, the black and white here. And then this with the color is the macular overlay. The lines that we have here, that's the pink line and the blue line, is the slice navigator. So the blue line would scan the macula in a vertical fashion from top to bottom, while the pink line would scan the macula in a horizontal fashion from nasal to temporal. Then at this point where my pointer is, we have the early treatment of diabetic retinopathy study grid, which has an outer circle, an inner circle, and then the innermost circle. The innermost circle represents the 1 millimeter of the central subfoveal field, which corresponds to the fovea. And then this retinal thickness, the measurement is taken from the internal limiting membrane all the way down to the retinal pigment epithelium. The total macular thickness and foveal thickness measurements are important in evaluating and monitoring of macular diseases such as the diabetic macular edema, the cystoid macular edema, and their impact on, that is age-related macular degeneration, and their impact on retinal vascular occlusion. Normative data on macular volume and foveal thickness is essential in providing a reference for comparison with findings in disease situation. So what we're trying to say that we need to have a normative data which is already imputed in the machine. And so when we send a patient for the test and we have the result, we have what to be able to compare with to know if the values we have there is normal or if there's a pathology. And we'll know if there's a pathology, if there's thickness as an increase, as we will see an increase in the value on the EDTRS grid, or if there's thinning, as we'll see a reduction in the value in the ETDRS grid. So it's very useful both in assessing how disease responds to treatment and in educating patients about the progress. The next that we'll see on the OCT is the OCT image finder and the fovea finder. Here, in this particular point, it helps us to place the marking exactly on the fovea so that there's a correct placement on the EDTRS grid, so that we are sure that we are taking the measurement of the fovea as desired. Then on this other part is what we have, the HD cross airline, which is basically the scan of the OCT. So we have here the black and white image, which is also represented here by the colored image. So the topmost here, we have the reading taken from the temporal to the nasal aspect of the macula, while at the bottom here, it's taken from the superior to the inferior aspect of the macula. So it's important to have good quality scan. What's important is to have good centration. Most scans will be centered on the fovea, but in some cases, if there's an eccentric scan, then to visualize non-central pathology, or because the patient cannot fixate adequately. So if the scan does not include the fovea, it's important to know why, and to now tell us whether we need to repeat the scan or not. So this is showing us the 3D macular thickness. Here we have the macula in a 3D fashion. And so we have these various colors. We can see the blue and the green, which represents cool colors. And so it's like the macula in this area is of normal value. While here that has the red and yellow represents hot colors, and it shows that there's that thickening of the macula at that particular point. Then with this 3D, it's now segmented. So we now have the segmented, first of all, we have it as the internal limiting membrane and the RPE. Then it's now separated to the internal limiting membrane and the RPE. Here, it helps us to localize the pathology, and we can get to find out when it's happening at a glance. At this point, we have the macular parameter, which involves the central subfield thickness, which this part tells us the innermost center, the innermost circle at the ETDRS study grid. That's the innermost circle, and that's where that reading takes place, the 1 millimeter. The cube average thickness, it takes the average of the outer circle, the middle circle, and the innermost circle to give us this value. And then we now have the volume here. So for the cirrus, this is the normal value that we have, the central subfield, then the outer temporal superior nasal. So when viewing the OCT macula, we need to ask ourselves this question. We need to be able to answer this question. How does the vitreomacular interface look like? What does the foveal contour, that's the premacular bossa, what does it look like? Is it of normal architecture? Is the retinal architecture altered, or it's normal in its feature? And then is there uniformity of the retinal pigment epithelium and the root membrane layer? Is there uniformity, or is it disrupted? We should be able to answer this question while looking at the OCT. So it's important to pause here and talk about the retinal OCT biomarkers. The United States Food and Drug Administration defines a biomarker as a characteristic measure of an indicator of normal biological processes, pathogenetic processes, or responses to an exposure or intervention, including therapeutic intervention. And they can fall into these 7 categories, which include susceptibility or risk, diagnostic, monitoring, prognostic, predictive, pharmacodynamic, or response and safety. So for the retina, we have the following biomarkers, which is important in clinical use, and it helps us in clinical use and research. So the various retinal biomarkers we have, the most common one that's commonly known is the central subfield thickness, which is seen in the ETDRS study grid. Then we have the ellipsoid zone, which is on the outer retina. And the ellipsoid zone was formerly known as the ISOS junction, which comprises of the photoreceptors. Then on this on the neurosensory retina, we also have biomarkers such as the intraretinal fluid, the subretinal fluid. The intraretinal fluid, this is a hyporeflective cystic space found within the neuroretina. While the subretinal fluid is found between the neurosensory retina and the space between the neurosensory retina and the RPE. Then the pigment epithelium detachment is the fluid that is found underneath the RPE. Other biomarkers is what we know as DRIL. That's this organization of the retinal inner layers. Then we also have the subretinal hyperreflective material, the RPE atrophy, outer retinal tubulation, and hyperreflective foci. Other biomarkers is the subretinal drusen deposits, the double layer sign, which is found in the space between the external limiting membrane and the retinal pigment epithelium. I will show some pictures as we move on. Then we also have the incomplete RPE and outer retinal atrophy, and the complete outer retinal atrophy. So this is my first slide. I will have to describe the different, what the arrows stand for. So this is the red arrow, and it's pointing at a white dot. This white dot is a hyperreflective foci, or is a hyperreflective foci, which usually would be indicative of inflammation going on, an inflammatory process going on in the retina. We have this white arrow pointing at a very large intraretinal cystic space, which is representing the intraretinal fluid. Then the yellow arrow here is pointing at the hard exudates. These are hard exudates seen in the neurosensory retina. Then this green arrow at this point is pointing at, there's this circle around here with a hyper-reflective border, which is referred to as an outer retinal tubulation. This, when it's seen on the OCT, is normally a representation of a neurodegenerative process going on here. And when we see that, it's indicative that there may be poor visual prognosis after treatment. Then the second picture here, we have the white arrow showing some subretinal drusen deposits. Here, this white arrow are indicative of subretinal drusen deposits. This red arrow is showing the hyperreflective foci that is going on, that is seen in the neurosensory retina. The slide to my left, the red line, the red arrow is showing, a subretinal fluid. That's the space, this is the neurosensory retina, and this hyperreflective line here is the RPE. So there's a collection of fluid between this, and so this fluid here is referred to as the subretinal fluid, which when it's seen, normally when it's seen in the OCT and it's we could start treatment, but it's also indicative that when we do start treatment, even if it doesn't resolve completely, we really would not worry so much about it, because it has a protective feature, as in it helps to prevent macular atrophy from taking place. Then we have this yellow line, which is representative of the pigment epithelium detachment. So there's a fluid underneath the RPE, and so it causes the RPE to have this the dome shape. Then the white line here below is indicative of intraretinal fluid, which is within the neurosensory retina. On the second slide to my right, the red arrow shows the Bruch membrane, while the black line is showing some irregular retinal pigment epithelium layer. The yellow line, the yellow arrow here, sorry, The yellow arrow here shows a shallow irregular, there's a shallow irregular retinal pigment epithelium elevation known as the PSI, which is one of the biomarkers, the retinal biomarkers. The slide to my, as we can see, this slide is showing a kind of like generalized atrophy of the retina. Then the slide to my right showing disorganization of the retinal inner layer, which will be seen at the fovea, that is the immediate, the central 1 millimeter. So when there's a disorganization, when we cannot make out the layers of the neurosensory retina, we would say that there's a disorganization of the retinal inner layer. So we will quickly look at some pictures to put this into practice. So we had said that the first thing that we have to look at for is the vitreoretinal interface. So in the vitreoretinal interface, when things that we commonly look out for is if there's a posterior vitreous detachment, which we could a posterior vitreous detachment, which could be complete or incomplete. We could look at we could find the epiretinal membrane, or macular pucker, vitreomacular traction, vitreomacular adhesion, vitreomacular traction. And the vitreomacular traction could lead to either a lamellar hole or a full thickness macular hole. So an epiretinal membrane on an OCT would appear as a hyper-reflective membrane, and it gives us this sawtooth appearance. So if you look at this OCT B scan, there is this hyper-reflective line at this point where my pointer is, and this is representative of the epiretinal membrane. And if it's sometime with the presence of the epiretinal membrane, there may be a loss of a foveal depression. The patient may present with reduced visual acuity or may complain of metamorphopsia. This is also another picture of the epiretinal membrane as seen here, giving off a sawtooth appearance. Then, in the vitreomacular interface, we could have the vitreomacular adhesion. Here, this is when when the vitreomacular interface, there's a separation, but it's not complete, and the fovea still has its normal contour. Then we would refer to it as a vitreomacular adhesion. But when there's a distortion of the fovea contour, then we would refer to it as a vitreomacular traction, as seen on the B scan on my right. So this is a vitreomacular traction distorting the normal anatomy of the fovea. The OCT also shows us macular edema. The macular edema could either be intraretinal, as seen in the neurosensory retina, subretinal, which could be in between the subneurosensory retina and the RPE. And in conditions where we have the macular edema, could be seen in diabetic retinopathy, the wet age-related macular degeneration, and the vein occlusions. It could also be seen in Ivan gas, as in post-cataract surgery. So this is a B scan of the macular edema. So these are various ways that the B scan can appear. We have we can see macular edema in branch retinal vein occlusion, in diabetic macular edema, which is cystic here, or in central retinal vein occlusion. So a vitreomacular traction could give rise to a macular hole. Give rise to a macular hole. And these are different causes of macular hole. These are different stages of the macular hole. This is a pseudo hole. It's referred to as a pseudo hole because the defect just stops at the neurosensory retina. It doesn't span the whole length of the neurosensory retina. It stops just short of at the outer nuclear layer. This B scan here shows a macular, a pseudo hole with epiretinal membrane. Then this is a B scan showing the outer retinal layer. So this part is the neurosensory retina. Then this part down here is the outer retina, where the topmost part is the external limiting membrane. Then this is the RPE. This is the ellipsoid zone. This is the ellipsoid zone. And this is the choroid. We have the drusins in age-related macular degeneration that will be seen at the level of the retinal pigment epithelium. So these undulations here are representative of drusins, and it's seen in the retinal pigment epithelium, at the level of the retinal pigment epithelium. This is a choroidal neovascularization as seen in wet AMD. And we have the central serous chororetinopathy, where we have the fluid. There's a fluid between the neurosensory retina and the RPE. Underneath here, this is a pigment epithelium detachment where we have the fluid underneath the RPE. This is a representation of the on the B scan of the OCT, where we have the outer retinal tubulation. This here, it's we would have a hypo-reflective space with a surrounding hyper-reflective border, and it's a sign of neurodegeneration. It can be seen in wet AMD, in geographic atrophy, and in some mitochondrial disease. The presence of outer retinal tubulation indicates that there's a disorganization of the outer retinal layers and irreversible photoreceptor damage, and so visual prognosis would be worse. So this is an OCT of a patient that had CRVO. This was taken before treatment with anti-VEGF, and this was now taken after treatment with anti-VEGF. So we can see that the visual acuity of this patient was 636. The macular thickness at that time before the treatment was 600. That's the central subfoveal thickness was 631 microns. So after treatment, it came down. The patient now had the 6/6 vision, and the thickness came down to 308 microns. This is another slide showing baseline OCT before treatment and 1 month after treatment. So the importance of this is that it shows us the anatomical findings, it's good in documentation, and then we can also use it to discuss with our patients and then tell them so that we can carry them along as we are giving them their treatment. So we would like to talk about the the wide field.
Hello, Dr. AGWEYE. Sorry to interrupt. we can give you a minute to get some water.
I would like to quickly talk about the wide field OCT. The OCT that we're used to is typically limited to 30 degrees in capturing of images. But in the wide field OCT, we have a range of from 40 degrees to 200 degrees, depending on the type of machine that we are using. And this is very important. It's very important to have the wide field OCT because it's going to give us the ability to assess the peripheral retina and also to assess or view the peripheral retina in high myopes. This in the wide field OCT, it's able to image the extreme of the peripheral retina, and so we'll be able to pick up some pathologies in that area. The challenge we have with the OCT that we have is that even when it now creates a montage, it's still limited in its depth of range. But with the wide field OCT, we have good depth of range, and so we will be able to have a lot of information to carry along and to make our diagnosis and to monitor our treatment. So in conclusion, the OCT is very important, is a valuable diagnostics tool for the retina specialist, and it assists in confirming diagnosis, understanding the pathogenesis of retinal diseases, and also monitoring effectively the treatment. Biomarkers are also important to guide in treatment decisions and offer advice on prognosis and risk of this progression. And it also helps in personalizing the care of patients diagnosed of retinal diseases. Thank you very much.
Yeah. Okay. Thank you, Dr. AGWEYE, for this very inciting lecture. So we'll move on to take questions. I would want us to drop our questions in the chat box where she will have access to them and would also have access to them. In the brevity of our time, we'll take as much as we can, and the rest of the questions will continue the discussion on the forum. Okay, thank you so much for the presentation, Dr. AGWEYE. It's been an exciting time. So we'll look out for the questions now. And if we're here to drop it in, if anybody that wants to speak can take their first question, but it has to be brief before we take the other ones. Thank you very much. So Dr. AGWEYE, the floor is yours as the questions come in.
Thank you.
Yeah, sorry for cutting in. While we are waiting for the questions, we'll prefer you drop it on the chat, because at times when everything is left open, we hear a lot of noise and we are not able to coordinate things as appropriate. So please, let's drop our question. We'll be able to see it. And while we are waiting for that, please, if you've not put down your name and your center, please kindly go ahead and do that also, so that we can have a proper documentation of all those who attended today. So please, let's drop our questions so that we can address all of them. Thank you.
So we're yet to get our first questions. It means that Dr. AGWEYE has answered everyone, or we're having network issues for the questions to arrive in time. So keep looking while we expect the first question.
Okay. So, write them out for me, please.
Yeah, so please, we have some questions here in case you missed them. Let me quickly highlight them. One is that, please, can you explain more how subtle subretinal fluid can prevent macular atrophy? That's from Eunice. And then Onyekwelu said, please, how do you differentiate between pigment epithelial detachment and subretinal fluid on OCT? So those are the two questions here now. Please, you can go ahead and answer them.
Okay. Sorry. Things hanging. Subtle subretinal fluid can protect macular atrophy because remember that there's a subretinal fluid occurs in the space between the neurosensory retina and the retinal pigment epithelium. And so during treatment, what we expect is that there's complete drying up. But remember that sometimes we do not want a complete drying up, because a complete drying up might lead to atrophy. And so that space would prevent, yes. That space between the so this is a subretinal fluid. This, where my pointer is a subretinal fluid. It's a collection of fluid between the neurosensory retina and the RPE. This hyperreflective line here is the retinal pigment epithelium. So any collection of fluid between this space is referred to as the subretinal fluid. Any collection of fluid underneath the RPE, remember that this is the RPE here. So if you follow it all the way, you now find out that the RPE is raised up at this point. So a collection of fluid between the RPE and the choroid is referred to as a PED. There's a pigment epithelial detachment. So as I was answering that, a subtle subretinal fluid would kind of prevent atrophy, because if there's a complete drying up of the fluid, we might have it overextend into the RPE and we develop macular atrophy, which we do not want to. So sometimes we just leave that residual subretinal fluid there because it's protective to prevent macular atrophy. Any other question? Which other question? I've just answered the subretinal fluid and sorry.
Okay, in case you didn't get the other question, it's asking that, please, how do you differentiate between pigment epithelial detachment and subretinal fluid? I think you've answered that in similar fashion. Yeah.
Yes. Then the next question is, how does retinal tubulation impact patient prognosis? The presence of retinal tubulation is a neurodegenerative sign of that occurs at the outer retinal layer. And so the way it impacts patient prognosis is that the visual prognosis will be poor, since it's a neurodegenerative condition taking place. The visual prognosis, if we see it on OCT and we're discussing with the patient, we would have a guarded visual prognosis. Any other question?
Okay, thank you so much, Dr. AGWEYE. We are right at the top of the hour. In the absence of further questions, I will rightly hand over to our chairperson for academic activity, that's Dr. Chibu, to take us to the end of the meeting and maybe give us some words, and our chairman to close the meeting. Thank you very much, Dr. AGWEYE, for your time and very interesting lecture today. Thank you so much.
Thank you for having me. Thank you very much.
Thank you very much, Dr. Ume, for moderating this session, and thank you for a brilliant presentation, Dr. AGWEYE. It was detailed, it was basics, and so I'm sure most people understood and can confidently look at their OCT results and be able to make a diagnosis based on the presentation you just made. So we appreciate you. And like we said, this is the foundation for our next presentation. This first quarter seminar or webinar is actually supposed to be in 2 parts. So we just had the first part now, which is talking about OCT in retina, interpreting retinal OCT. The next session, which is coming up in the next 2 weeks, will now deal with OCT angiography, fluorescein angiography, indocyanine angiography, and we implore you all to be part of it because it's going to enhance your practice, enhance your skills, enhance your management of patients. Thank you all for joining us in this very brilliant presentation by Dr. AGWEYE, and have a very good night. So, Mr. Chairman, sir, I don't know if you have any more remarks to make before we close up.
Yeah, I'd just like to appreciate everyone for coming, and we look forward to seeing you all in a fortnight. And then thank you to everyone, the great presenter, the moderator, and everyone that has come tonight. See you all in a fortnight. Good night.
Good night.